Sure. Good evening, everybody. Sorry, this is not, this is, yeah. So hope my screen is visible and I'm audible. So this is about 24 years old lady whom I started seeing for last 1 year, even though her problem started somewhere even before that. She's a homemaker, and when she came to me, she was only 22 years old. Well, she came during COVID time and she had some allergic rhinitis too. The problem started somewhere in 2022 when she presented to a local doctor with grade 2 dyspnea on exertion, intermittent cough, and breathing difficulty. She was initially hospitalized and managed elsewhere. However, her CT scan chest done in 2022, it was recorded in her progress notes that it was suggestive of interstitial lung disease. But because of persistence of her symptoms, she came to me in January 2023. She was nicely worked up in all her connective tissue disease workup except borderline SCL70 positive. Everything was negative. When I examined, she didn't have any features of CTD or even ILD. Her saturation on room air was 96. She had tachycardia. BP was slightly on a lower side, but no signs of pulmonary hypertension. This was the report which I was talking about. And Mithun, if you are there, you can comment about it. Otherwise, we will, when Mithun joins, we'll ask him. And this is her
Hi,
correct.
ma'am.
Mithun, what do you think? Is this significant?
SCL70 in ILD, it should be taken significant, but the intensity of in immunoblot is just mild. What you usually see in systemic sclerosis is usually 2 plus or 3 plus. But if patient has features of any scleroderma, this has to be taken as significant. One way, other way is to do this by a different method, by ELISA method, which is also available but little costly. We have to send it outside. In our hospital, it is only the Western blot technique. And without skin manifestations, scleroderma can present. We call sign scleroderma. Therefore, we have to take it. We cannot ignore this completely. That's what I can tell.
Okay. She didn't have any features of systemic sclerosis skin.
One more thing I will tell. The IFA, no? IFA is negative.
Yeah.
This should be taken as false positive, because if SCL70 is positive in immunobody, that is significant. ANA by immunofluorescence should be also positive.
Should be positive.
Positive.
Yeah.
Therefore, it should be taken as negative or false positive.
Sure. So I will move on to CT scan, and I will stop sharing my screen. And while Bhavin sir is sharing his screen, I would tell you that when she came to me, she just got married, and she was telling that at her husband's house there was some exposure which was aggravating her features, and I suggested her to go to her own house for a few days. And that is what there was a suspicion of hypersensitivity pneumonia, even though I can't recall what exactly was the exposure.
Okay, so can you okay, can you see my screen, these images?
Yes, sir. One mediastinal, one link.
Correct. So this is from December 2022. And what we're seeing are these ill-defined reticular opacities. But what you see is this classic subpleural sparing, which is quite interesting. But we also see areas of septal thickening, all right? So while there is an interstitial component, the question is, what is it that would be so diffuse, presenting with a little ground glass with reticular opacities and so much subpleural sparing? And importantly, she has bilateral pleural effusions. And, typically effusions and, interstitial lung diseases don't go hand in hand unless you have a connective tissue disease with a serositis, or there is a cardiac component or something like that. So
Was there a pericardial effusion, sir?
There is no, there's no pericardial fluid.
Okay.
A little bit of hepatomegaly, if at all, but that's kind of pretty much it. And this is unusual. I mean, there is some organizing pneumonia component. In fact, If this patient had a cardiac issue, I would even start thinking of a pulmonary edema component. But there's some kind of a mixed picture here that is, occurring diffusely. Now, she comes back in May 24. So we'll just put all of them together here. So the ones on the top row are the May 24 scans. And you can see that whatever it is, there's significant improvement. So when I align all of these together, you've just one sec. That's fine. I'll align it later on. So if you see these, just at, let's say in the lower lobe level, all of these findings have significantly improved, or, these are the residue of whatever was the prior insult happening at the time. So in a way, you could even argue that what you are seeing in 2022 is just an acute diffuse lung disease. Now, whether it's an acute interstitial pneumonia, whether it presented as a, like a DAH or an acute viral or whatever, and this is the residue in 2024 at the top that we're seeing. But she still has these bilateral pleural effusions, which is very unusual again. And again, whether this is just some residue, whether there's thickening rather than fluid, which ultrasound would have shown, I'm not sure. So this is where we are. Some residual reticular opacities, axial distribution, and significantly less than in 2022.
Is there any fibrosis?
There is no fibrosis per se. There's no traction bronchiectasis. There's no honeycombing. There's no reduction in volumes. There's nothing that would suggest fibrosis.
Any way this looks like post-COVID, sir, which has resolved over a time?
So 2022 scan doesn't really look like COVID. I mean,
Okay.
it could be something else. It's too symmetric, so even if
Yeah.
you were thinking of H1N1 or something, those are usually asymmetric as well. And what you're seeing is just a diffuse, ill-defined process, which is axial, peribronchovascular, some kind of an OP pattern. I mean, I would just classically name it as an acute interstitial pneumonia of indeterminate etiology, and then leave it at that, and now say that there's significant improvement with some residual changes that are there. Can we 100% say this is not COVID? No, we can't, because COVID has always had unusual manifestations. But it's on those lines. It's some acute insult that occurred and seems to have improved. So one other point, that we learned during COVID, if you see the anterior-posterior diameter, right, of the lungs, which is reduced here because of whatever is the diffuse process, when things start improving, these anterior-posterior diameters dramatically improve. So from 10.5, it's become 11.5. You got a 1 centimeter improvement in excursion,
Yeah.
telling us that whatever it is has improved significantly, allowing all of these other things to happen as well,
Sure. Yeah. So I'll just continue. So sir has, yes, you stop sharing then.
Yeah.
So what I did is because there was a significant doubt about hypersensitivity pneumonitis and she was only 22, just got married, they were not willing for biopsy. That was the time when I started her on steroids. And currently she is on omnacortil 10 milligram alternate day or 5 milligram daily kind of. And over a period of time, they have significant financial constraints. So I could manage only one CT scan. That is what we showed. And because she didn't have old CT, we got it. And that is how, even though I did it in May, we have discussed now only. So this is her pulmonary function test, which we did in January 2023 when she came. And then I repeated somewhere February now. So we can see there is improvement in all the things. 6-minute walk test she didn't do because she was in a hurry, but she is not desaturating anymore. Her echo was not showing pulmonary hypertension. Her PFT is showing improvement. Now she's on 10 milligram. And the questions to the panel is it CTD, ILD or HP? Because HP was what I was treating her for. Should I be doing biopsy anymore now? Because I didn't consider it in the first place. The reason I am discussing is she is planning for pregnancy and they are worried about the steroid part. I am giving her 10 milligram. I can safely come down on 10 milligram to 5 milligram also. But will it be safe? Will I, if I come down, will it increase or not? That time only will tell, that I can't ask. But should I discourage pregnancy, or is there any better option if a patient wants to become pregnant? Rajan sir, if you can.
Did this look like HP at all, Bhavin?
No, no, not to me, no.
No. So obviously, whatever it is, responded to steroid, Asmita.
Yes, sir.
And her autoimmune workup was as good as negative, according to me.
Yeah.
But could this be just labeled as an atypical pneumonia, Bhavin, for which we don't need to do anything more? I'm just thinking.
Yes, I agree with that.
Yeah. Alpa is also here since we don't have Alpa. Your thoughts? Any thoughts, Alpa?
Yeah, so her lung functions have significantly improved. So definitely, and radiologically also she's better. Only thing, DLCO is not improved to that extent. So DLCO is still quite low, 46%. So I mean, of course, we need to continue her on some immunosuppressant. And if she wants to get pregnant, I think steroid should be fine. Or sometimes our rheumatologists, they start on azathioprine, that is also okay. But in her case, since she responded well, maybe continuing the same dose of steroid and monitoring her over a period of time is what I would think.
Yeah, I mean, even steroids, I mean, there's a small risk of cleft palate, right, in the first trimester, Alpa. So that's barring that, steroid should be fine. Azathioprine, I'm not too sure about. But if you're a rheumatologist, what does Mithun say about that?
No, sir. I don't think we need to add azathioprine.
No, not in her case. Yeah, agree.
We can reduce steroids because less than 10 milligram is safe.
Yeah.
Instead of continuing 10 milligram, we can come down on steroids.
So currently she's on 7.5 milligram, Asmita?
10, I believe it is, I just made it 5 milligram, not 7.5. From 10, we make it 5 only.
5 is okay. 5 is okay.
So that should be okay.
Anything below 10 is fine. Anyway, we cannot give MMF, right?
No.
Yeah.
Azathioprine also, I don't think it's needed.
Yeah.
Whether we can taper and stop, that may be difficult, no?
We will decide, but I don't want to try it when she wants to become pregnant and all.
We can ask them to delay pregnancy by 1 year or 2 years.
Yeah, I delayed it for 2 years now.
That's a very difficult thing, you know. For a young lady when family is deciding, that's very difficult to counsel. And I think there is no need because she's done pretty well. I mean, by more than 1 liter, her FVC has improved. And we are not even sure of the etiology. It may stabilize at that level and it may not worsen. So it's just that I think currently while she's pregnant, we should continue the same dose of steroids and monitor her.
Yeah, I think that's what seems logical to me. Anything Amila or Bodhika wants to add?
Yeah, Amila, Bodhika?
I think steroid would do the thing, no? Like.
Sure.
Yeah, I think
the job. Yeah.
I agree with you. I think my only concern, first of all, I'm sorry for the delay. I was a bit delayed to join you.
No.
But my only concern that this could be a disease in evolution. So we should have some sort of a monitoring for this patient, continuous surveillance. But this could be an evolving disease. Because she has some residual fibrosis that I can see in the repeat CT scan. And even though the autoimmune screen is negative, it could be the initial insult could have been an infection, but it could have been an autoimmune or whatever process that which might progress. So I think we can further wean off steroids, but only thing we should have to have at least careful monitoring of her that she might evolve into something else.
I strongly agree with you. I personally didn't feel that it was only atypical pneumonia because the way she improved, it took long time. It didn't happen because we treat pneumonia and people improve. So she has definitely something. Mithun, is it worth repeating autoimmune workup now?
No,
because
no need.
Okay, fine. Okay, I think I'll just share my screen for next case. So we have got answers here and I'm happy with that. I'll move to second case. That this is also a follow-up case which I have already discussed once somewhere in July. So he's a 64 years old man who is a shop owner. He's an accountant or something like that. He doesn't have any occupational exposure, but he was a smoker, just stopped smoking for last few years. And he had coexisting asthma also, for which he was using inhaler, comorbidities, diabetes and hypertension. He also had COVID, but that was long back, and exposure to biomass fuel and pet animal, which is dog. And he presented to me somewhere in May 2024, presented with persisting shortness of breath. He had ICU admission requiring mechanical ventilation somewhere in October 2023, and we had CT scan of that, which I have discussed earlier also. When I saw him, he had saturation of 92 and other things were okay. Bilateral basal crepitations were present. His ANA profile A1 plus, ESR was high, CRP was borderline. PR3 MPO was negative, and myositis profile was also negative. Now I'll stop sharing. Before we go to this thing, we discussed last time, and the main doubt was whether it is, my diagnosis was CPFE, and Bhavin sir's diagnosis was it is only panacenar emphysema, and we treated him for both, but unfortunately, for last 3 months, last 1 month, this is his third admission. He is admitted with me right now, even though he's not on ventilation or anything, but I could not remove him from BiPAP. They have decided for palliative management, so he's not for ICU, but still, if we can offer him something, I would be happy to know from the panel. So these are all his CT scan, and over to you, Bhavin sir. You muted or you're not talking?
Sorry, I was muted.
Yeah.
So you can see these three scans, right? October 23, April 24, and October 24. And sorry. So if you look at the first one, we have clearly a combination of, a confluent centrilobular substantial paraseptal emphysema, which is all in the upper lobes. No significant interstitial lung disease, and that's why I must have said at that time that it's not CPFE, it's just emphysema. The right middle lobe is atelectatic, a lot of inflammatory bronchiolitis in the lower lobes. But I think the big thing is this consolidation. So the patient had a superadded pneumonic consolidation in the right upper lobe with a little bit in the left upper lobe as well. Then in April 24, there is significant improvement. So we can appreciate all this emphysema much better here. And at this stage, there is no significant infection except for some infectious bronchiolitis in the lung bases. And now again in October 24, he's come back with a lot of ground glass in the upper lobes, which is again a superadded inflammation, infection, acute exacerbation, something on those lines. If you look at all the three scans, I think we can clearly see the upper lobe consolidation here a year ago, improvement, and now again there is an acute exacerbation. But the background is severe emphysema, upper lobe predominant, also a small airways component, etc.
So there is no fibrosis as such, sir?
There's no fibrosis, no.
So all those bronchiectasis changes which are happening in the upper lobe
are just part and parcel. So a lot of this is not bronchiectasis, it's just emphysema, and the rest is the residue of the prior pneumonia. So each time I think he has a pneumonia, it leaves behind a certain level of, bronchial dilatation and bronchiectasis.
He recently the last admission was 2 weeks before, where he had oral ulcers and my dermatologist told it is HSV. So can it be like I was thinking, is it HSV pneumonia which is happening? I
Could be. I
treated
mean,
him. Yeah.
that we cannot tell. So it's some pneumonia, some viral, some acute exacerbation. I mean, there's no way. This could even be PCP, CMV, anything under the sun.
Yeah, so PCP is something which I should cover for, which I'm not doing right now. Anything like I'll just that's it, na sir. I will share my screen, my questions. Yeah. Oh,
I think
Katrina has
Katrina
come.
joined.
Ah, hi.
Oh,
So
hello, everyone.
yeah, hi. So this is April 24. Presently, I wanted to do, but he's so moribund. I can't do his pulmonary function test right now. He's bedridden, so I am not able to do. In between, from April to last month, September, he was okay. Last admission was HSV. 3 admissions in last 2 months, and now coming with worsening of dyspnea, and he is dependent on NIV, and that is why I have put it for discussion. And even now also that it is looking like COPD. I was just thinking that the ground glass opacity, is it a part of exacerbation of ILD? But you don't feel that is ILD, right, Bhavin sir?
Sorry, I just stepped out for a minute.
There is no interstitial lung disease
No,
according
there's
to
no
you?
interstitial lung disease at all.
Okay, Katrina, did you see the thing?
To be honest, I saw only the CT, but I don't know the history. Um, I think it is there is a background, but mostly the background is of emphysema. I don't see a clear background of fibrotic lung disease, but I don't know the history, so I'm blinded to everything. So I am rather a radiologist
Sure.
than a clinician. Yes.
Yeah, Rajan sir.
How is the patient doing now, Asmita?
He is like, if you ask me, he is stable. He's stable in a way that if I'm putting him on NIV and oxygen, he will maintain oxygen level of 90 to 93%. But as soon as we remove, or even if he changes his position, his tachycardia and everything worsens. There is significant anxiety component for which I have started him on morphine and all. So family members are clear. So I was just wanted like anything other than transplant we can offer to him, because that is something which they are not willing for.
That means he has a bad airway disease, right? With a largely no interstitial involvement.
Yes.
And you have his lung volumes and diffusion now?
No, presently I wanted to do, but he cannot move. He cannot perform it. So the last one which is done is bad. It was around 20% of DLCO. Just show you.
And any pulmonary hypertension on the echo?
Presently, I didn't do, but no, on the last it was not that. 59% of KCO and 58% of DLCO. FeNOPA and FVC was 66%. That day also we discussed this, and everybody opined that it looks like more like a emphysema rather than this. What I was thinking of. So my only doubt was like, is there still fibrosis going on? But no fibrosis.
Yeah, so I mean,
Can
you're
we
talking about
see-
transplant. What's his PCO2, Asmita?
PCO2,
Yeah,
we have ABG, and ABG is not showing. It is 7.49 pH with 30s PCO2 and 60s on oxygen, 60s PaO2 kind of. It is not type 2 respiratory failure.
And his PO2 on room air? PO2 on room air?
On room air, he will maintain around 90% or something, because he's very tachypnic when he breathes and all. Lots of effort, lots of muscle effort is there.
And he's got a barrel chest and emphysema type features?
He's slightly lower side of height, so I didn't feel it was typical of emphysema features. He's just continuously breathless. He has clubbing. He has mild peripheral cyanosis.
Oh,
And
clubbing is very uncommon in
yeah.
COPD.
Clubbing and peripheral
No, but
cyanosis.
Clubbing is not common in COPD. Katrina?
Not likely. There was a one lung nodule, Bhavin sir. If you are there, you told me to have a watch on that lung nodule, and this time my radiologist has reported that the left upper lobe nodule remains status quo in the size. Did you see, sir?
But that won't make him hypoxic.
Yeah, that won't be. But if you ask me, clubbing is very uncommon, so malignancy can be the feature. But I don't know. It is not increasing in size. Even if it is there, it's not the reason.
Any chance
However,
of doing a ball lavage?
I didn't do last time because last time his CT was clear. This time he's very sick. The relatives just wanted me to discuss that if
how
I am
old
missing something. He's
how old
hardly 59, 62 kind of.
does he have a family history of a lung disease?
No, nothing.
BAL?
I didn't do BL. This time he's very sick.
Okay, any exposures? No.
One pet that is a dog, not birds or anything. And fuel
Okay.
because he was working where office he was working, that was some petroleum. He was working in Gulf countries. So mostly it was a petrol product which he was exposed to.
Yes.
He,
One other solution could be, I don't know if he or she is a heavy smoker
he
or
is.
not.
He is a heavy
Is
smoker.
yes, and
Just before 1 year.
he developed emphysema earlier on or late in his.
Very early on, many
No,
years.
okay, so I would measure the levels of alpha-1 antitrypsin.
Okay.
Yes, because maybe he could have an opportunity with this therapy. Moreover, I could, let's say, treat him as CPFE and to measure their BNP pro BNP in order to be sure and with echo the presence or absence of pH, because in this phenotype with this CT and with this background of such a severe airways emphysema structure, fibrotic disease like emphysema in CPFE, you mean this texture is not so, evident to differentiate in the CT because we have different infections on the top, acute exacerbations on the top. So we have a mixture of parenchymal and airway diseases. So it could be related to a CPFE phenotype the patient is prone to develop PH. That's why DLCO and the volumes, etc., are very, very low. And also, I don't know, KCO, or if we had initial measures. However, this phenotype is more prone to lung cancer and PH. So we could consider him as a phenotype of CPFE if we don't find alpha-1 antitrypsin deficiency, because if we find this, we can treat him with the drug, if available, with bronchodilators plus everything for COPD. But if we don't find something to treat, because we can treat him with treatable traits, what we can target to do to help him. If not, we can, sure, with DCT, treat him as CPFE, exclude PH, exclude lung cancer, and with this phenotype, I think that you can also initiate nintedanib.
Yeah, thank you for that. Anything
It is not-
else?
it is not a-
One more question.
It is not
Sorry.
a malpractice. It is not a malpractice to do because we don't have other things to do, as far as I understood.
I agree.
COPD with lung cancer, I'll accept, but Katrina, there was no fibrosis, so can we call it CPFE?
I didn't see exactly the CT, but in the CPFE phenotype, you cannot differentiate very well the fibrosis from the emphysema. And as we have a phenotype which is not responsive, who is not responding to COPD treatment, if we don't find a level of there is some central fibrosis, and in the, can I see the basis?
So there's no fibrosis,
Okay.
there's no interstitial fibrosis. It's just
No, there are, yes, but the CPFE, you cannot wait for the, the real fibrosis. It is this kind of texture. And there is subepithelial fibrosis, not in the basis. I don't know if you listen to his chest, if he has any crackles, but I think
He had very typical. The reason I suspected CPFE was because of his clubbing, because of his clinical
Yes.
findings.
Yes. So I think you can label him as CPFE because CPFE is, I don't know how is going to, to have any,
Improve, yeah.
benefit with
Respond,
antifibrotic.
yeah, I agree.
Yes, but you can treat the treatable, and
Sure.
you can try to stabilize him, measuring first any family history of telomeropathy, early gray hair, something that we can, have a fibrotic, let's say, or the monocyte count, to have any evidence of fibrosis somewhere else. It is also something that we can ask,
Sure.
because and I would treat him if not with alpha-1 antitrypsin therapy, in case which is a targeted therapy. I would treat him with both antifibrotics, nintedanib in this case, for CPFE phenotype. And if also the patient has a cancer, it could be also a treatable trait. Or I could go to the periphery and to do like there, to do a CT biopsy through the CT in order to exclude cancer.
Yeah, my question to
If
Bhavin sir is, this
also-
pan-acinar emphysema, why it is so localized to only upper
But
lobe?
it is not pan-acinar emphysema, and I'm very confused right now because the definition of CPFE that we have been following for the last 10, 15 years.
I
is that-
am in the, I don't want to say something more. I am in the definition of this committee, and I know exactly what
Correct,
CPFE.
but there is no
I'm
fibrosis.
I'm trying to help with a treatable trait for this
Yeah,
patient.
sure.
Yeah,
It is
but
not a
It's okay, it's
typical,
okay.
it is not a typical CPFE,
yeah,
but
it's-
because in the CPFE we don't see all this kind of, you are right, but I think there is a huge background of emphysema in all things.
So smokers get emphysema.
Can't we?
20 plus pack years history smoker.
Agreed.
I think I'm clear. I don't say that it is a typical phenotype of CPFE. I say that there is also something which is fibrotic texture, which can be labeled like this to help the patient, maybe, if,
Sure.
on the top of the COPD and others treatments. I think I'm clear. I didn't say that it is a CPFE phenotype.
Sure.
But the patient is like,
This patient is not doing well also, so I just wanted
Can't
to
we
ask.
do sort of serial follow-ups, HRCTs, and decide on
We already have three of
Three,
them.
yeah, and
Three,
there is,
okay.
and I don't know how much follow-up I will.
Right.
He is very sick.
Those improvements.
Sorry,
He's very sick, yeah.
is he a current smoker?
No, he's not a current. He can't, like as I told, he can't even move. So definitely he's not a current smoker right now. He stopped smoking for last 2-3 years. The last admission was somewhere in 2021, which required mechanical ventilation, and I don't think he was in a position to smoke anymore after.
Should we move on?
Yeah, I think so. Like because we
Yes.
we are not getting anywhere. I'm sorry.
I gave some ideas.
Definitely, I am so happy for that. Thank you. So the third case will be Madam Alpa Madam's case. I'll just share those slides. Yeah. Are you talking, Doctor?
Yeah.
Yeah.
This patient was a 44-year-old lady, married, homemaker with 2 children, no comorbidities. She first presented in April 2021 with shortness of breath. Dyspnea was grade 2 since 2019. So when she came to me, already 2 years, she was having symptoms of grade 2 dyspnea. Her predominant complaints were the chest pain and heaviness. Okay. And that was also going on since 2019. So that time she had some old HRCT films, which was reported as sarcoidosis. And I also agreed with the report because there were perilymphatic nodules and fissural nodules, and it was quite typical of sarcoidosis. But ACE levels were normal. We did her CTD workup because she was a young lady, and that was negative. And when we started her on steroids, she showed good clinical response, but she had a lot of reservations about using steroid. Then from 21 to December 23, she was taking some bed treatment outside, and she was put on azathioprine 100 milligram per day. Prednisolone was continued 5 milligram per day, and she was on inhaled corticosteroid with formoterol. And she was not following up with us. And she came back in December 23, and history and her paper showed that in between she had received multiple short courses of oral steroid for worsening symptom. And mainly her symptom worsening was with chest pain and heaviness. Next slide, Asmita. So she came back to her OPD in December 23 with a similar complaint of retrocentral chest pain and palpitation. Breathlessness did not worsen, it remained grade 2. And when she came to us in December 23, she was on azathioprine 100 milligram per day and prednisolone 5 milligram per day. And on this dose, she was having worsening of symptoms. We did her serial PFTs, which I will show you. It did show a drop in her lung function. At this point, I started her on methotrexate 15 milligram per week, and 7.5 milligram a day, 2 times in a week. Continued with her prednisolone 5 milligram per day, and for a short period, for about 4 to 6 weeks, I had increased the dose. The current dose of 5 milligram per day. Her symptoms of chest pain, dyspnea, and exertion improved, but she still keeps on getting this intermittent worsening of chest pain. And whenever we try to reduce the prednisolone to less than 5 milligram, her symptoms of chest pain increases, and the pain increases especially on lying down. Next slide, Smita, please. Yeah. So you can see here the pulmonary function we have from December 21 to September 24. And it has significantly shown a drop in her FVC, FEV1 of course, and DLCO has dropped, which was 58% in December 2021, and now 3 years down the line, it is 49%. KCO is more or less maintained, and total lung capacity is also shown significant drop from 3.77 in December 21 to 1.94 now. So there has been serial drop in the lung functions, lung volumes. DLCO, KCO has not dropped that significantly. Next slide, please. And recently we did her 6-minute walk test.
Sorry, can you go back, Dr. Alpa, in the previous slide? Just a moment.
Yeah.
Yes, okay, thank you.
And so recently, Dr. Sujit Rajan also has seen the patient, and 6-minute walk test was done at Bombay Hospital. You can see her predicted distance was 58% of predicted. The 6-minute walk distance. There has not been much desaturation, just 1%. And even shortness of breath or fatigue was not too much. So she's physically quite active. She does her regular exercises. She does her yoga. And she's able to carry on her activity of daily living and even social activity. Predominantly, she's complaining of chest pain and heaviness. So this is what is the history. Bhavin, can you show the CT images.
Okay, so currently we have this one CT that was done in September 24. First, I'll just run down from the apex to the base so that you get a sense of the pattern of disease. And then I'll just come back up again. So what we have are reticular opacities now showing an axial distribution. They're going from the hilum to the periphery. Lot of this perilobular pattern that we have here. And then if you see, there's a lot of fissural nodularity that you see throughout, here. You also have these perivascular nodules that you see. So in the upper and mid zones, we see fibrosis with traction bronchiectasis. We also see these perivascular fissural nodules. There's no significant zonal predominance. You can appreciate that perilobular pattern very well in the lower lobes too. No honeycombing, but it's clearly a fibrosing ILD. So fibrosing ILD, non-UIP, non-IPF, and highly suggestive of chronic pulmonary sarcoidosis. The MPA is also dilated, so there should be a pH component. No significant adenopathy at present, and nothing additional that we see on the soft tissue images. Now, when we look at the older ones, we only have films, and the one that I have is from 21, right, which shows.
Sorry, can I ask if
Yeah.
the first one is at the time of diagnosis of sarcoidosis?
No, this is current. This is the current one, the September 24.
Yes, but when the lady had the diagnosis of
This one.
sarcoidosis,
This is
with
this.
this one. Okay.
So
But
unfortunately, I can't.
We don't know how the diagnosis has been reached.
Yeah, this is one of the reasons I told Alpa we should get this to MDD.
Sorry,
We don't have a biopsy, Katrina. That's right.
Okay, or BAL, etc. Okay. So we have a CT diagnosis of sarcoidosis,
Yes.
and then the patient came with this. Okay. Sorry for the interruption.
Mhm. No, so that's it. So then this is the 21X CT, just one film. And you can see the significant progression of disease. I mean, I think that's the best thing. I can't really appreciate the pattern very well, but there's significant, progression. And there is a CT that was done in March 24, but that kind of pretty much shows the same thing. So I don't think there's much progression between March 24. I think there's an April 24 as well. Sorry, this is April 21. So there were 2 scans in 21, and now we have this one here. So this is where we stand. So just to show something interesting, I mean, sometimes when we want to be even more sure about the sarcoid and all of that, we can try some stunts. So if you look at, minimum IP images at 3 millimeters, you can actually see the whole pattern of, the perivascular nodules, the fissural nodules, so much better when you manipulate the images a little bit. So it just gives you a good sense of the axial distribution here. That's it.
Okay. So I'll show you the questions and then maybe one of you can take. Yeah.
Yeah. So the question to the panel would be, are we considering any other differential than sarcoidosis? Should we do bronchoscopy, ball and transbronchial lung biopsy? And what would be the treatment options now? Whether to up the dose of steroid? Should we start antifibrotics at this stage? And what should be the long-term prognosis for this patient?
So before you all go ahead, just from a radiologist perspective, while all of these findings look so classic in the setting of a fibrosing ILD, if it was non-fibrosing and the findings were classic, it's different. It would always be a good idea to prove the diagnosis with some biopsy if possible. Alternately, a PET CT to see if there are other lesions in the body somewhere else that could be biopsy, maybe lymph nodes in the abdomen, neck, which we are not seeing, but it's always a good idea. That's about it. So that's my 2 bits, and I will keep quiet.
Yeah, I also had an opportunity to see this patient. I mean, Alpa and I discussed her case. She's quite anxious, and the problem is that she has dropped lung function when Alpa started dropping her steroid dose. So the easiest thing to do would be just bump up her steroid dose, continue methotrexate, but she's young, and I felt that moving forward, if this gets into progressive fibrosis, then we're really in trouble. If we have to look at newer therapies which are likely to come in the future, we need a biopsy. This is what I thought. Katrina, I'd really like to hear your thoughts.
Yes, I very much agree with it and our radiologist. Sorry, but I don't take time to pronounce his name very well. But I'm sure it is a fibrotic lung disease, which is progressive. We know that the disease is progressive also with lung physiology. We know that the disease is rather, let's say, responsive to steroids or not, Sujit?
I think it is. Alpa has seen him much
Yes,
longer than I have, but I sense that she was better, and Alpa was trying to get it off, considering she's young.
Yes, but we
That's why the
have,
methotrexate came
but
on.
every time when we have given a higher dose of steroid, she's responded. Her chest pain and shortness
yes,
of breath has remained more or less stable, but chest pain used to always respond to the dose of steroid.
By any
However-
chance, you repeated ACE level in between when she was not responding?
No,
It will
we
be
haven't.
worth checking.
I'm not
Okay.
sure
I
if that's
would
really
check. Probably, I think we have repeated once, I think, but it was not high.
However, I would go for a PET to see other peripheral sites of a biopsy because BAL at that stage will not give us a lot of information because of the steroids. So we will not see a lymphocytic pattern, blah, 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 which will be helpful because the patient has been under steroids. So I would try a biopsy first beyond the lungs, if it's possible, to an easier target. But I would like a diagnosis because she is young. Steroids is not a solution, and other solutions are different between IPAF, CTD, ILD, feature, etc. It seems that it is non-IPF, of course, fibrotic disease, progressive disease. So we have other things to exclude, chronic HP, etc. So I think, or maybe a flavor of a CTD. She's young, she's a woman. So let's be careful about the diagnosis. If we can do that with a PET, to confirm sarcoidosis, this would be, I think, easier. But I won't go further, retreat here with a lot of steroids and immunosuppression, because maybe we will have other options for a young lady, as she's also anxious and she deserves to be anxious, according to my opinion.
Sure. Yeah. We are seeing Murli, sir, or
Murli's
Yeah, so
taking off.
no, I'm here.
yeah.
Sujit, I'm here.
Yeah. Yeah. Anything,
Sujit,
sir?
I'm here.
Yeah.
Yes, sir, we can hear
We
you.
hear
We
you.
can't
Please
see
go
you,
ahead.
but we can
Go
hear
ahead,
you.
Murli.
Yeah. No, so I'd agree. I think the biopsy is a good idea, but I'd also like to focus on what Bhavin said about the pulmonary hypertension. Why does she have pulmonary hypertension? Is it, which group does it belong to? Have you done an echo recently for her? Because that would explain some of her breathlessness and
So
the decreasing
echo is not
6-minute walk.
confirmed. 2D echo is not showing pulmonary hypertension.
1 year ago,
Okay.
it was normal. It was normal. Yeah.
Yeah, so normal.
Right. Okay. But I'd agree with the rest of what Professor Katerina said. I think a biopsy is a good idea.
Anybody
But-
wants to add anything more?
Antifibrotics, any take on antifibrotics at this stage?
I would wait till you prove the diagnosis, Alpa. I mean, we need to get some tissue here and probably bump up steroids, see if she gets much better, and then take a call on that. That's my thought.
Okay. So
I think we go to next case.
Yeah.
Yeah.
Sure.
Okay.
Sure.
Fine.
So the next case will be the case one of Dr. Sujit sir, and that is Mr. JK.
So Mr. JK everything is summarized in this slide. And Alpa, please stay on because I need your thought also here. 59-year-old male, sari salesman, lives in Mumbai, never smoker, except his father who smoked, whom smoke he was exposed to for 25 years. Hypertensive, ischemic heart disease, and he was just given steroids for 20 years for his asthma, prednisolone. And the poor chap just kept taking them. And then when I saw him first, which was that time we got him off the oral steroid, and he had a mild COVID attack in 2021. After that, he was lost to follow-up. He was well. And now, since April 24, he's been having intermittent streaking hemoptysis. And his breathlessness is not severe. Met him just yesterday in clinic. He's breathless, walking up steps for the last 5 years, but he also had an MI in 2017. And no autoimmune symptoms, family history negative, scattered wheezing, and this was the blood work that we had. Can see all this. The only thing that came up somewhat positive was a Me Too with a 2+ on the blot. ANA was 1 in 160. His lung function is clearly showing airway disease more than restrictive lung disease, as you can see. We only have one lung function. The lung function I got done on him in 2017. For some reason, he's lost it. But severe airway disease, as you can see here, DLCO reasonable, not normal. 6-minute walk test drops to 95%. His echo pulmonary artery, estimated pulmonary artery pressure 45, and he has akinesia and hypokinesia in certain parts of his heart, as you can see on the echo post that MI. And that's why his ejection fraction is 30 to 35%. And because of the streaking hemoptysis, since April, I got a scan done, and that's what actually surprised me. And so, Bhavin, maybe you'd like to pull that up.
Okay, so this was the radiograph in April, just so that you put it in your mind, and I'll come back to this in a little while. But this is basically what we had. So let me run from the apex here and go down to the base. Just a quick overview, and I'll come back to the findings here. So if you see the upper lobes, there's no interstitial lung disease. There's a mild centrilobular emphysema. He is a non-smoker, but whatever the reason for that, and as we come down, starting with the superior segment of the lower lobe, we start seeing these reticular opacities with interspersed ground glass. Again, it's predominantly left lower lobe, much more. You also see these areas of, septal thickening everywhere, which is a little interesting. And then in the right lower lobe, you start seeing the same findings. It's a combination of, so you see this very lacy reticular appearance. It's kind of predominantly septal thickening, some interspersed lucencies, but pretty much just this appearance. And you also see these bullae or cystic areas interspersed with these lesions. When you reconstruct the CT, and you can actually see both of these here, I just kind of made a chest X-ray simulation out of the CT. You realize that these lesions were not really there in April. So it is an acute, subacute process that has developed over the last 3 to 4 months only. And when something happens like this, and you get all of this septal thickening, localized, asymmetric, lower lobes, my worry is of an infiltrative process, in terms of either neoplastic It could be inflammatory, infective, lymphatic, whatever. But something that tells us that the first thing, and again, when you see these cystic areas here interspersed, when you don't have that kind of emphysema in the upper lobes, all of this is very, very worrisome for a neoplastic process, according to me. And so that's what I put in my report, that this is infiltrative, requires a PET CT, and then we target with whatever form to get a biopsy done to figure out what's going on.
Can chronic pulmonary edema give this kind of picture, Bhavin?
Without an
Yeah.
effusion, without involvement of the perihilar regions, no. I did think of that, but no.
Do we have any BNP or I agree that it is we don't have the classic butterfly, as our radiologist has confirmed, but I would also exclude the heart failure, and sometimes it is not typical. So BNP and echo is always useful and non-invasive to a patient. And
So-
I would go back to the history if possible.
Yeah. Can we go back to the history slide, Asmita?
Yes.
I think I also thought of chronic interstitial pulmonary edema, Katrina, and you can see the echo findings on the last two lines. And he's so much better. I did talk to him about a biopsy after I saw Bhavin's report. He's terrified of undergoing all that, but if push comes to shove, we'll have to do it.
Yes.
He's saying I'm fine now.
Sorry to interrupt, but
Yeah.
I think what Katrina is saying is right. Pro-BNP is a great thing. We don't do enough of it in the
Sure.
settings, but if you can show that it was high and it's come down and the patient's improved, and then just repeat a CT to see
Yeah.
if the lesions have regressed, that would prove the diagnosis. But if not, then
Yes.
a PET would be. So let's say these lesions persist after. So this was 6 September. We repeat, let's say 6 weeks from then,
Yeah.
which will be around 6, 13, 20th of October. And then if they persist, do a PET first and then see what's going on, rather than a straightforward immediate
Yeah.
biopsy.
Yes, I also agree because we have an injection fraction of 30 and 30%. The DLCO is very low. So I would go first to exclude, if possible, other things, heart failure, PET,
Not
so
very
lung
low.
cancer.
Katrina, not very low. 54, 55, 56% DLCO.
Yes, but we have other things to do, and I
Yes,
don't know if
yes.
biopsy would be, one other issue that we can discuss is if he had wheezing, and a history of asthma, how do
Yes, he has history. In fact, I saw him first in a charitable OPD 7 years ago. And so I was treating him as an airway disease, with his father having exposed him to passive smoke for 25 years. Now, because I have stopped going to that outpatient,
yes.
he came and with the history of hemoptysis, that's why I got the scan done. Otherwise, I wouldn't even have got a scan done probably.
Do we have any evidence of obstruction?
There is lung function. Smita, just pull up that lung function.
Do we had any eosinophilia? Because with
No, not so much. The eosinophil counts with 2% of 8,100. And
So-
FE on FEC ratio is 59%, as you can see. This is
Yes.
obstructive airway disease. RV TLC ratio more than 130% predicted. TLC 81%.
Yes, so maybe how many eosinophils in the blood? How many?
Just about 160.
160. Is it under steroids or not?
No, he's not. He was on steroids for 20 years till 2017. He was just taking it regularly because he was a poor man. And so some GP had put him on prednisolone 5, and then we got it off. We managed to actually get it off. And he's not been on prednisolone since the last 7 years.
I would go further to exclude if he could be benefit of mepolizumab or other treatments for severe asthma, which sometimes is very also very much related to bronchiectatic and hemoptysis lesions. So maybe, I don't know if our radiologists could further comment if there is some evidence of bronchiectasis or lesions that could be related to asthma. However, a severe obstructive pattern with the history of late onset asthma with even 160 of eosinophils, we could go with biologic therapy, and in the meanwhile, to exclude heart failure and with PET, any cancer to this patient.
My biggest challenge is he's
Yes.
a poor patient, Katrina, and
Poor,
he's
okay.
he's fine with inhaled steroids, LABA. And
Ah,
if I offered him biologics, I need a fairly convincing argument to prescribe that.
okay. So he's not, he has a controlled asthma. He does not have.
Yes. He's quite
Okay,
comfortable,
okay.
just grade 1 exertional dyspnea.
Okay.
Upper
I
chest.
try to put everything in a basket.
No, it's
But
interesting how you looked at it. It's very
yes.
interesting how you looked at it.
Yes. However, I would start with the heart failure because this is the more easier thing to do, and then I would go for a PET.
Yeah, and I hadn't got a baseline pro-BNP done before he got better. So I agree, a lot of this is useful when you have patients who can get these tests done more easily. But none of that was available, Katrina, and he is better. And I also think maybe when do you think we should scan again, or Bhavin, if we just do a plain scan again?
Sometimes wheezing, if it is not related to asthma, would be also related to cardiac failure. And I don't know, I didn't, of course, you have listened to his chest. However, sometimes there is wheezing in the end of expiration, and there is also this kind of crackles that are not crackles, but are, this bronchi with a little bit of humid, inside.
Right.
But
I definitely don't want to biopsy him if this is all heart failure.
yes.
So,
We all agree. Let's go non-invasively.
yeah.
Just one question, Sujit. Did you notice any change in the amount of crepitation that before he got better and now?
Yes,
So,
slightly less, I would say, maybe slightly less. But he has a
probably everything is
silent chest.
fitting.
Yeah.
Probably everything is fitting more into congestive heart failure. Even the hemoptysis could be related to CCF and the kind of shadows that are seen, which were not existent in the previous X-ray, and now you see the lesions.
The problem,
and you are not seeing that much of fibrosis, right? Bhavin, there's not much of traction bronchiectasis or
No, there isn't.
correct.
also
So
more
everything is
unilateral, Alpa. It's more unilateral.
Bilateral left, it's only
less on the
located
left, right? Is
left
only
in
bases are
the-
involved.
Yeah, but it's not, so it's very unusual. I mean, to see a cardiac failure without, pulmonary edema, just lower lobe, without, any fluid anywhere else, all of that is unusual. But point taken, I think if we can repeat a scan at 8 weeks, maybe around the 6th of November, and then take it from there. I mean, you could just do a chest X-ray, and if everything's cleared off, then maybe you don't need to do anything. But if the opacities are there, then we move on further.
Chest X-ray wouldn't make sense,
Quite a few patients, I don't know what is the observation of others. These patients who got intractable cardiac failure, they do develop this, interstitial edema, and then we are never been able to get them to improve their lung function. They become, progressively hypoxic. You don't find anything else. So I do not know whether this chronic edema gives rise to some kind of process of fibrosis but I've seen quite a few of these patients who have chronic congestive heart failure and they progress to hypoxia. And diuretics also don't help.
Those are the bad
Further,
ones, right?
Dr. Shankar, sir.
Yeah, Mela.
I'm just wondering whether prawn film would help. I mean, the next time when you're emerging.
Bhavin's done that.
And
I think he would have
all
done
right,
it.
okay.
Yeah,
Dr. Shankar, do you have a prawn film with this in the CT
It's
scan?
the same. There's no change.
All right.
In fact, that was the worry, Amila, because there's no change on that. And then this infiltrative word came into the report. I had to have a conversation with the patient and his son. And they are better. As Alpa said, now they're better. So I think I will just repeat a scan and bring this patient back to MDD with the fresh scan to just so that everyone knows what's going on.
Absolutely. I
That's
think
great.
that's the right.
Sujit, can I add something?
Yes, Murli, please.
Yeah, sorry. So, we know he has COPD. There is evidence of that. We know he has asthma. So those you're optimizing already. We know he has heart failure, so that needs further optimization.
Right.
How was his coronary artery disease treated? Was it just treated medically?
Medically.
Okay. So
Only-
I think all three have to be optimized first. But what I
Yes.
would do after 2 or 3 months is not do just a plain CT. I would probably do a PET.
Okay.
That me too, and the word infiltrative there worries me a little.
Sure.
Yeah, so that's a 2+ MI2 is not something I would ignore easily. And he has a history of smoke exposure, and the evidence of that is in his COPD.
Sure.
So that's probably what I do. That's the only difference that I would make to all his treatment. And I would probably put him on triple therapy for his COPD/asthma.
He's on that. He's on that.
He's on
Yes,
it.
That's super. I think, shall we do the last follow-up? I think very interesting inputs here. Yeah, so this gentleman, just a quick follow-up on this patient, Asmita. This gentleman we had discussed in the previous MDD. He had ankylosing spondylitis with sarcoid, if everyone recollects. But we were not 100% sure, so we did proceeded on to biopsy. Can you run through the slides? Yeah, we did a CT and a PET. And I think Bhavin will also remember this gentleman. He had one of those very rare patients with Bhavin where there was a slight air leak after the biopsy, and post-bleeding and pneumothorax tissue was inadequate for microbiology, so we sent it only for path. Ritu had seen these slides and had said there were very, very, very well-defined granulomas, but we wanted to differentiate between tuberculosis and sarcoid. He had lost some weight also. And then we did the PAN CK, which was negative, if I recollect, Ritu?
Yes.
Yes,
Yes, Dr.
CK was negative. And the other stain you did was
the Von Cosa to enumerate the Shaman bodies, which was positive.
Yes. So we got those, and it all was suggestive of sarcoid. And so we decided we will, because he had dropped a lot of lung function, as you all know, pulsed him for 3 days, 2 months ago. Prednisolone, he's now on 7.5 milligrams a day. We followed what Athol has been advising us from Brompton, that once you pulse, bring down the dose to 20 milligrams. He's now on anyway, he wants to get off steroids. He's gained 3 kilos. He's at about 80% of his original energy levels. Murli, I don't know if you recollect this case we discussed.
I do.
You
There
do,
is this history of exposure to silicates. So
correct.
Yeah,
I remember.
zinc.
Can you continue the slides, Asmita?
Yeah.
Thank you. Yeah, and no, previous slide. Yeah, he's very keen to get off steroids. He's not very young, but he's not very old either. He had those bladder lesions on the ultrasound, we did an ultrasound, bladder lesions have improved. So that was also probably getting better with steroid. And this is his lung function. Next slide. So we had a lung function, the level he was in 2002, that was the time he was a keen, avid squash player. Since 2014, he has stopped playing squash. But what it had dropped to, he was quite bad. As we know, he was desaturating in June. He is now not desaturating that much. Walk distance improved. His lung function has come up to 70% predicted. 2.87, not near his April 24 levels, 2.87. Well, my questions are very clear. I want to wrap this up because I know we have passed the 6 p.m. mark, especially to Katrina, who sees much more sarcoid than all of us see. Katrina, he wants to get off steroids. Should we move to methotrexate or adalimumab, considering he has associated ankylosing, since we have a good response to steroid? The CMR is in abeyance now. We are not doing any fresh biopsies because of the response to steroids. People were worried that if he doesn't respond to steroid, we need more biopsy. What is your thought, Katrina?
I think that firstly I agree with Athol. I also know that very well. When we pulse the patient, then we have the lungs in the very, very best, but then we have to move gently to 20 to 25, not more. Here we have a disease which is responsive to steroids. This is a good idea of adalimumab, as you said. I would go to a further biopsy, but methotrexate is a good drug for sarcoid. And I would like to stop steroids or to not use a dosage more than 7.5, which is actually what we produce every day. So if we can, let's say, control the disease and the quality of life of the patient with a 7.5 or more or less 5 to 7.5 dose of steroids plus a good dose of methotrexate, I would stop there. If I would go to, to treat more disease, etc., or I would try something more, but not altogether. But I would go to biopsy again. I don't think so.
And so if cost was not an issue, would you prefer adalimumab or methotrexate? He's never taken methotrexate, and he took 3 months of steroids, 10 years ago.
Which is the background of the other disease beyond sarcoidosis that you said?
Ankylosing spondylitis.
No, I would like to treat him first with methotrexate. Yes.
Okay. Yeah, that's what I wanted to know because cost here is not an issue at all.
We can combine later on.
Okay.
And
would you choose then infliximab or adalimumab?
Adalimumab, maybe.
Okay. Yes. Okay. So I think that answers his question. He wants to get off steroids like today.
Yes.
But he's at 80% of energy level. So I said, give me a few more weeks and we'll get that off. But I will recommend that we get on to methotrexate. Murli, Amila, any thoughts here? Alpa?
No, I completely agree with Katerina. I would go for methotrexate first. And I would actually attempt to take him off steroids completely.
Sure.
Yeah, totally
I'm
agree.
going to board now, Sujit. I'm going to stop speaking.
No problem, Murli. Thank you from an airport to join in from the airport. Thank you.
Thanks.
Okay, bye, everyone. We're done, right?
Yeah, no, we're just waiting for
Amila.
Thought, Alpa, any other thoughts?
Yeah, I mean, I too totally agree with Katrina because I think we should start MTX and come out of steroids as soon as possible. Right. And later we can consider biologics like adalimumab, but I think the first line would be the steroids, I think, after the steroid. Sorry, first line would be methotrexate.
Yeah. Sure. Super. I hope some of y'all whoever's tuning in is at WASOG because we will have the first paper on upfront methotrexate versus upfront steroid presented. And so that's exciting. And
Wow. Oh, we will,
So that's the
we are
predicate
excited.
study.
We are excited too.
That's in 1 month's time.
Bhavin
See,
sir, can I
yes.
ask you one question for last case of our Rajan sir, that infiltrative disease? Was
Yes.
it anyhow looking like sarcoid?
No,
Bhavin?
no, no, no.
No, okay.
No.
Because I was thinking that we do not have a reason for his congestive cardiac failure. He was getting steroids for quite some time, and then steroids were stopped, and then all the things happened. So I'm not sure what was steroid treating. That's why. Anyway.
Okay. You're saying there's no ischemic heart disease with no intervention gone on there. Yeah, I got your point. Yeah. Whether we
So-
go on the CMR route and all.
Yeah, so it's worth doing PET CT to find out is there any other system involvement also or not. And regarding congestive cardiac failure, it is a very easy clinical diagnosis. So if we are not making a clinical diagnosis by raised JVP and edema fit and this and that, and then we are suspecting, to get a diagnosis of CCF is like doing a rectal examination of tonsil. I really doubt that is not
No.
that.
I
Yeah.
think
Oh,
you're right.
Advita,
Your points are good, Smita. I've noted them down. I think cardiac, also airway disease you can get in cardiac, in sarcoid. You can get an
Yeah.
component.
And he was getting steroids for quite some time. So we should think that of mine. And he's 59 and he has a very bad heart disease without any family history, not diabetic. Why should he develop all those things? So can it be a part of a single disease which was I think masked by steroid effect? I don't know. Maybe I'm just thinking of that.
Anyway, this was superb. I think next time Athol will be there, but with Alpa, Amila, Katrina, Ritu and Bhavin, we haven't missed Athol. We need to tell him that today.
Oh my God, he was.
I think he will be in the plane now because I have texted him. So
Yes.
No,
now
Sujit, Rajan sir wanted to tell him that we do not miss you, kind of. Rather than everybody telling him we miss you. Okay.
We
So
have
we
him next time. Next time he's there.
Yeah, we'll have
Okay.
on 25th October with Vimal Raj sir, I believe.
Thank you.
Thank you so much.
Thanks, Bhavin. Thank you.
Thank you,
Thank you.
everybody.
so
Take
much.
care.
It was a very, very active.
Yeah, it was good input from you, Katrina. Thank you so much for joining.
I tried my best to have an holistic approach, but when you don't have the patient or you don't know him very well, it is not very easy to do that.
Yeah, I understand.
But they were wonderful cases. Sorry, I was a little bit late, but I have to go to ICLAF, but first to Athens. But first I came in Larissa, which is mainland. So just travel by car transfer after 3.5 hours. So just came in my room. So thank you so much
Thank
for the
you.
lovely
Thank you.
visits, and it was a huge pleasure to see you all again. So
Thank
see you
you.
very, very soon.
Thank you.
Thank you.
Bye.